Hello, everyone. Good morning, and welcome to the first lecture of neurology. And as you know, what is neurology? By definition, simply, neurology is a field of science which deals with all the conditions with our neurological system. And what constitutes the neurological system is basically the brain, the spinal cord, the nerves. Okay, all these things, of course, make our nervous system. So, neurology, like simply you can say, it's a branch of science which deals with the disorders of nervous system. Nervous system, brain, spinal cord, peripheral nerves, and not just these, but like for example, epilepsy, uh, which is a disorder of brain, Parkinsonism, disorder of the brain, neuritis, a problem with the issue with the peripheral nerve, or all these disorders, all these neurological disorders. Neurology is the one which deals with that. And the person who specializes in neurology is called as a neurologist. And many countries, it is considered as a branch of internal medicine, but in many other countries, you can say it is a special field, a different field, simply. For example, in the United States, neurologists, they go for complete neurology training uh, in the field of neurology. But like in many other countries, for example, if you will do fellowship in the UK or Ireland, you have to do some rotations in internal medicine as well, and then you train in neurology. Anyhow, that's a different discussion. So, whenever we, what you can say, start something new, so I always talk about the examination because we are studying neurology from clinical point of view. One thing, guys, which is very important, I would like to mention here is you can never be good in neurology, okay, especially um, to tell you, for example, uh, stroke. Now, stroke is so wide and so broad topic that many people who do neurology they especially specialize in, or the subspecialty they do is called as stroke medicine. So, if we will talk about stroke, for example, uh, in that thing, all is the game of localization. Like someone who had stroke and he have weakness in the upper limb, someone who had a stroke he have a weakness in lower limb, someone who had stroke he have weakness on face and the other side of the body, or someone who have stroke, uh, he have aphasia or memory loss, things like this. So clinically we have to examine the patient, and we have to reach the site, the uh, area of the brain which is damaged. A brain is of course very complex. So uh, why I'm mentioning this thing, it will be hard for you to understand these kind of topics if you are not good in neuroanatomy. Okay, so if you have time, uh, try to go through the neuroanatomy. Try to learn the different parts of the brain. Try to learn the different areas of the brain. Try to learn the different centers in the brain. Where is the language area? Where is the motor area? Where is the sensory area? How they're associated? How different tracts, they are interconnected with each other. What is basal ganglia? What are different nuclei? What is brainstem? What is the function of cerebellum? What is the function of midbrain? What is the function of the brainstem? And what are the different tracts which are passing through the spinal cord? What are the functionality of different tracts, as well as what is the nerve root? What is a dermatome? So you can say too much knowledge is needed to understand the clinical side of neurology. And if you haven't done that, of course, it will be hard for you to understand, especially stroke. Okay. not just stroke but many other conditions. So like it's my suggestion to you guys that try to go through neuroanatomy. And for neuroanatomy, uh, as far as I know, of course, different books are available, but one of the very good book is Snell's Neuroanatomy is a good book. It tells you many clinical points as well. It tells you the clinical correlations, and it will guide you more towards, like, it will develop more clinical orientation when you are going to study Snell's. So let's start with neurological examination. Okay, so like, when we talk about, for example, abdomen, respiration, or cardiovascular, for example, uh, there is more like this thing that you have to do inspection, palpation, percussion, and auscultation. Neurology is a little different, okay? Because in this one you have to go through a little different type of examination. The steps are different, and uh, it's a different it have a different pattern. But to start with, for example, uh, in like whenever we do any examination, uh, the first thing is the general appearance. Okay, we always see the general appearance, how the patient looks like. Okay, general appearance. So, for example, when you look the patient, if you found that he have a drooping right side of the face, so of course you can catch it. Mm, you can catch if the patient is sitting in a different posture, if his hand is flexed, leg is extended, pointing towards stroke. For example, when you see the general appearance and you found that someone have pin rolling movements in the hands, Parkinsonism. So general appearance will give you a lot of information. What can be the possible disease or condition the patient can present with? Okay, so this thing is important. And of course, like after general appearance, we go to check for the vitals. And in vitals, of course, we check what? We check the pulse, we check the blood pressure, we check the temperature. Okay, we check the respiratory rate. Okay, we check the respiratory rate, we check the oxygen saturation. Okay, of course, like all these things are vitals. So in pulse, when we check the pulse, of course, rhythm is very important because for example, atrial fibrillation, these are the people who are having increased risk of getting uh, thromboembolism. So pulse, always check the pulse, like either it's regular or not regular. After that, like once we have checked the vitals, then we go for like into the GPE. For example, you can examine from head and neck examination. Okay, so in head and neck examination, of course, like you can catch a lot of things. For example, you can see the eyes, you can see, um, because the patient can present with multiple conditions. For example, in the eyes, if you can see battle sign or raccoon eyes, or for example, when you're examining the ears, if you found that there is blood coming from the ears, hemotympanum, or if the nose is runny, and the runny nose is basically what you found, like when you do test, you found that the CSF is leaking. So of course all this point towards the fracture of the base of the skull. uh, uh, when you examine the neck, for sure, like if there is uh, you can say if there is neck uh, stiffness. Okay, so it could be meningitis. When you check, for example, the mouth, if you found someone have bites on the tongue, so maybe it can be a patient of epilepsy. Okay, so see, head and neck examination is very important. So we in head and neck, we examine the eyes. Okay, we check the pupil size, we check either the pupils are reactive to light, either they are same size. Okay, they are equally reactive to light. We do a direct light reflex as well as the indirect light reflex, and all these things we can see. And the tongue, as I told you, for epilepsy. Next stiffness, I already told you. So this thing we can do for head and neck. We can go for head and neck examination. We can also do CVS examination. Why CVS examination? For example, we go and we try to hear carotid bruise. Okay, or for example, you will look for heart murmurs. Why? Again, as I told you, that carotid bruise, like many of the people, their carotids are blocked, and we can hear the carotid bruise on their carotids, which can go into the anterior circulation of the brain and can cause stroke or heart murmurs. If you will talk about someone who have atrial fibrillation, of course, like they will be having heart murmurs. Okay, so we can do CVS examination. We can do mental status examination. Okay, now what is mental status examination? See, uh, how you would know that the patient is either alert or confused or lethargic or in stupor or in coma. One thing, we always check for to do level of consciousness is called as GCS, which is Glasgow Coma Scale. Okay, and in general surgery, I already talk about GCS, right? Like how to assess the GCS, and we had a good lecture on that. In trauma, to be more specific, I teach you this thing in trauma. In the hospitals, in the emergencies, we check the GCS of the person, uh, just to see either the patient is alert, either the patient is what is the level of alertness of the patient. Simply that can be assessed by GCS. And if you remember, how we check the GCS: the motor, the visual, and as well as the verbal command. The motor have 6 points, the verbal have 5 points, and the eye opening have 4 points. So simply we check the GCS. Other than GCS, just to check the level of consciousness, you can also check the orientation of the patient. Okay, orientation of the patient. What is orientation? If the patient is oriented in person, time, and place. Okay. For example, if someone is coming to you uh, and you found that the person is um, for example, I'm just giving an example. For example, the patient is under the effect of alcohol. So maybe the person is not oriented in person, time, and place. Maybe you will ask what's the time. He cannot tell you. Maybe you will ask him like who is he is. He will say I'm a king. Or maybe you will ask like where he is. He cannot tell you. So whenever we check orientation, we check in like either the person is oriented in um, like the person is or like that patient should be oriented at the person, time, and place. Okay, so this by this way we can check the orientation of the patient. One of the thing in neurology is called as cognition. Okay, we have to check the cognition of the patient. So there are, what you can say, there is a number of things you can say. You can tables or different type of tests are available to check the cognition of the patient. Okay, so and to many of you, by the way, who don't know what is cognition, cognition is basically uh, can be defined as, you can say, the thought process or the like how much the person can do its intellectual functions. Okay, uh, in that one, we can check the orientation, we can check the attention of the patient, we can check the memory of the patient, we can check the knowledge of the patient, we can check the judgment of the patient. Either the person can reason the things or not. Either the patient can comprehend the things or not. What is the language of the patient? Okay, so of course, like cognition is basically the higher mental functions uh, which you're performing all around the clock. Okay, if your cognition functions are intact, if I will ask you, for example, who are you, you can tell me. If I will ask you, can you please do this, like can you please close your eyes, you can do that. If I will ask you, can you write a sentence, you can do that. Can If I will ask you, can you interpret what I'm saying, you can do that. So that is all cognition. Okay, the reasoning, the evaluation which you can do, the judgment which you can make, the memory which you have, and all these things, of course, the language and all these things, comes in cognition. So to check the cognition, guys, there is a lot of tables that as I told you. One thing is called as mini mental state examination. I will show you, by the way, what is mini mental state examination. The full name is uh, Folstein mini mental state examination. Uh, mini mental state examination, like the chart which I'm showing you guys here. I remember this thing. This is not to diagnose any condition. This is a screening test. Okay, this is a screening test. Um, it cannot diagnose anything, but it can screen the patient. For example, if the patient is having delirium, or if the patient, or it will guide you that maybe the patient have some problem in some of the parts of the cognition. Okay, so the total marks is 30. You don't have to memorize this table, because in the hospitals uh, these type of charts are available. So see, we ask the person what is the first we ask the patient name, we ask the patient the way we ask the patient name, we write the date, we ask like what is the profession of the patient, education, because the result of this mini mental state examination depends on varies a lot according to the education level of the patient. We ask the patient either they are right-handed or left-handed before starting that, and then see, uh, these are the marks which are written. You will ask, what is the year, season, date, day, week, and month. One, two, three, four, five things we ask. If the person is telling correct the year, the season, the date, the day, the week, and the month, 5 points. We ask like, can you tell me where you are? What is the state, county, town, city, and floor? You have to ask five things, 5 points. Then we point towards three things and ask them like, can you tell me what is that? For example, if you're holding a pen, you can point over that, what is this? Or if you can show him anything, 3 points for that. uh, oh sorry, this is not naming, sorry. Actually, what is this? This is registration. This is called as registration. Okay, so there is registration and there is recall. So in registration part, what we do, we ask the patient that I'm going to say three things, and you have to keep in mind that. Okay, and you have to repeat that, uh, like when, like for example, I will tell the patient I'm going to say three words, and you have to repeat those three words after me, and uh, remember them, because I'm going to recall that during this uh, test, right? So I will say him, pen, paper, and anything like chair, and he will repeat, pen, paper, and chair. And then we go for this thing to check the attention of the patient. We will ask them to spell the word world backward. So we see like either they can spell it backwards like DLROW, or one more way is like you can do one, either one of these. You can tell them that count 100 backwards, subtracting 7 each time. So if for example they are naming, if they can spell the word world backward correctly, all the five, so 5 marks for that. And then we ask them to recall the three words which we tell them before. If they can recall the three words, so we give them 3 points. For example, the patient who have dementia or delirium, maybe they cannot recall the words back. Okay, they sometimes the patient cannot register, sometimes the patients cannot recall. What is significance of that? I don't think so. Like you guys should go more in, right, in this lecture I will go more in details about that. And then we show the patients two simple objects, okay, like a wristwatch or a pencil, whatever you have, and ask the patient to name that. So if he can name both of them, so 2 points. Then we ask them to repeat no, ifs, and or buts, and if he can repeat, 1 mark. Then again, see, we give the patient three stage command like take a paper, fold it into half, and put it on the floor or put it on the table. So if he is performing those three tasks, so 3 points. Then we ask them, please read this and do what it says. So for example, the instruction says close your eyes, so the patient will read and he will close his eyes. Basically, this is designed because this one is checking many circuits in the brain: your visual auditory coordination, your visual uh, uh, eyes coordination, muscles coordination, all this stuff. Then we ask the patient to write a sentence. Okay, write a complete sentence about anything. So The sentence must contain a noun and a verb, and then we ask the patient to copy this figure, okay, and then they copy. If they can copy, so 1 mark for that. This is basically to check their language, this is to check their attention and all this stuff. So 30 marks are there, okay. uh, this is called as MMSE, mini mental state examination. This is a screening test, it's not a diagnostic test, and it's a bedside test, can be done within 5 minutes of time, okay. There are many others. For example, I will show you this one. Montreal Cognitive Assessment, okay, MOCA, MOCA. This one is also a 30 marks, what you can say, cognitive test, which is designed a bedside test. Again, not a diagnostic test, but like anyone who is scoring like 26 or more than 26 is considered as normal, okay. So in this one we are also checking like visual spatial or naming, memory, attention, language, abstraction, and recall and orientation. See, date, month, year, day, place, and city, and all the stuff. So it is like somehow more or less the same. There are some special tests, guys, for to check for the cognition. For example, when you are going to study dementias, you would know that there are tests to check for the frontal lobe testing. There are tests to check for like some special kind of dementias. Okay. Uh, so like what I'm checking until now, like this one, this all things until here is simply, so MMSC is there and MOCA is there, right? Or Montreal, this one. So this neurological exam until here is basically what we are checking is we are doing journal physical examination with mental status, okay, of the patient, of course, okay. So all these things which we are checking is basically these things um, until now. So once you have done this thing, guys, so then we will move on, of course. um, the rest of the thing, of course, depends on the history which you have taken from the patient, okay, and depending on that you will decide like what you have to do. For example, of course, like here I can talk a little about all the examination. For example, after that we will go for cranial nerve examinations, okay. Cranial nerve examination. Whenever I give the lecture, face to face, I always ask the patient, the students, the names of 12 cranial nerves, because that is the most important thing. I think a bare minimum concept, students should know at least the names of all the cranial nerves, and it should be in the sequence. Why? Because when we examine these cranial nerves, in reality, we go in the same sequence. Okay, so like simply. Um, uh, Olfactory, optic, oculomotor, trochlear, trigeminal, abducens, okay. And then there is facial, then there is vestibulocochlear, then there is glossopharyngeal, uh, and then there is vagus, and then there is what you can say, accessory or spinal nerve, and the last one is hypoglossal. So simply we go in the same what you can say, um, same way when we examine them clinically, okay. So like this is like how we go in reality. So after cranial nerve examination, of course, we can do what you can say, you can go for motor examination, okay. uh, Motor examination, of course, like there is a mnemonic which I love, that is called the IT. Cranial nerve examination detail, I will talk in a while, of course. Like, I don't want to go enter in that, because right now it's an orientation lecture and I started talking about neurological examination, so better to like tell you the whole thing and then go on individual parts, right? So one mnemonic which I love is called as ITPRCS. Okay, so ITPRCS. So what is I? I is inspection. Of course, you are going to see that motor area which you're examining. For example, if you're examining the upper limb or the lower limb, first of all, you will see either like there is any atrophy, any asymmetry, any bulk. How is the bulk? Okay, any deformity? What is the posture and all the stuff. So after that, tone, we check like either there is hypotonia, hypertonia, okay. Then we check the power of the muscles, okay. And then we rate the power depending on the uh, how much is the power. There are tables given in different books, by the way. For example, someone who have normal power, it is 5 by 5, and then someone who have a little less power, 4 points. Someone who have um, that much power that he can lift his limb from the against the gravity, but not against when resistance is applied, so it is 3. And someone who cannot live, like even lift the limb against the gravity, uh, but can only move the limb on the bed when the gravity is not there, so 2. And someone who can just give, what you can say, a little jerk without any movement, it is 1, and otherwise there is 0 power. Then we go and we check for reflexes, okay. Depending on, what you can say, uh, the limb which you're examining. For example, if you are examining the upper limb, uh, you are going to do a bicep or tricep reflex, and if you are going to examine the lower limb, you are going to check the ankle reflex and the knee reflex, okay. C is for coordination. Coordination, like, we can ask the patient, for example, to um, repeat some movement again and again, okay, just to check like either both of his limbs are going in some coordination or not, because many of the cerebellum condition, this coordination is lost. And the last one is sensations, okay. We check the sensations. In sensation, we check the pain sensation, we check the temperature sensation, we check the vibration sensation, or we can check the proprioception. What is proprioception? Simply, again, it's one of my favorite questions, which I usually ask the students, like how they can define proprioception. Uh, Proprioception is basically, if you will close your eyes and someone is going to move any one of your joint, you still know what is the orientation of your joint in the space, okay. So basically that we get just because of we have intact proprioception. And simply, what you can say, um, the proprioception is simply, you can say, it is the sense of the joint position is called as proprioception, okay. So this thing, sensations, we check for any abnormal movements in the person. For example, if there is any tremors, any chorea, any hemiballismus, any myoclonus, okay, uh, thing like this. And like, of course, like, so no matter you are checking like the upper limb or the lower limb. So see, this is the motor examination, and of course, like, you can, when we examine some limb, we go in this one. But as we are discussing right now all the neurological examination, so I will make sensation as a different thing. So sensations, whenever we check the uh, pain sensation, temperature sensation, vibration, and proprioception. Basically, see, as you know, like, the vibration or the proprioception or the 2-point discrimination, they are carried in the posterior tracts, fasciculus gracilis and fasciculus cuneatus, which are also called as the fast tracts. Okay, so these two we check to check the fast tracts. And uh, crude touch and pain, temperature, sensation, these one are carried by the spinothalamic tract or the anterior tracts. Okay, so we check this one. So we check the motor system, we check the sensory system, and uh, after that we can check the what you can say, coordination, okay. Coordination we can check, as you know, like, coordination, I told you, it is like basically the patients who, what you can say, cerebellum problems, the patients, they lose coordination. So we do the coordination check. There are different ways, there is a finger nose test, okay. To what you can say, to check, there is a heel shin test, okay. In the upper limb, if you want to check, you can do finger nose test, and the lower limbs you can do heel shin test. or you can do a rapid alternating movement test. Okay, better to see some videos on what you can say on the YouTube. And the last one which we can check is the gait. Okay, in gait, like of course we ask the patient to walk. Okay, and we see like either they have any problem with the gait or not. For example, there are different type of gaits. Someone who have pain somewhere, it is called as intalgic gait. Okay, someone who have a stroke, so that is called as hemiplegic gait. YouTube have all the videos for these patients. Okay, then there can be ataxic gait, then there is fascinating gait. Okay, um, you can found a foot drop, for example, in any patient. There is a very important gait called as broad based gait, for example, in cerebellum problems and all this stuff. You can do one more test called as Romberg test. Okay, don't worry guys, I'm going to talk about all these things in the coming lectures. Okay, right now I am just introducing how we do the neurological examination, and that's why I'm going a little faster. So see, the neurological examination as a whole, you have to do general physical examination, you have to do mental status examination. In this one you have to check the head and neck, CVS. Okay, you can do some tests like mini mental state examination, you can do Montreal cognitive assessment, we do cranial nerve examination, we do motor examination of the upper limb and the lower limb, we do the sensory examination of the upper limb and lower limb, we can do coordination of the upper limb and lower limb, we can do the gait examination. Okay, as a whole. So basically when we check coordination, basically what we are checking is uh, what basically we are checking is cerebellum problems, right? So the important thing over here, you can say, which I would like to mention in my first lecture, by the way. Of course, like it's very hard sometimes, when the patient is new and like it's like in reality, of course, like the clinicians or the consultants, they don't go in all the detailed examination, rather they do the relevant clinical examination. Okay, whatever like is required. So what they do is called as screening of neurological screening neurologic examination. Okay, neurologic examination. So of course it is a quick way, you can say, to screen out if someone has some problem or not. For example, what I will be doing if a patient will come to me, uh, and I have to screen out just to check, catch like if the patient is having some sort of you can say a neurological problem or not. So for sure, like the first thing I will check is the mental status of the patient. Quickly I will check the orientation. Quickly I will check the GCS. Okay, then I will go and I will do the head and neck examination. Okay, and head and neck examination I will check for any lacerations, any bruising, any signs of basal skull fractures, any uh, signs of meningism or meningitis. Okay, if the patient is traumatic patient, I will check his back cervical spine, if there is any fracture, if there is any tenderness in that area. Quickly I will do a cranial nerve examination. Okay, uh, and of course, like I will not go and do all the cranial nerve examination, rather it's a screening test. So yes, I will check his visual fields, I will do a fundoscopy, I will check his pupil size, I will do the light reflexes, I will check his eye movements, I will check his facial strength, either his face muscles are all powerful, and if needed I can check his hearing in both of the ears, either they are fine or not. Then I will move on motor examination. Quickly what I will do, if I will do the whole neurological examination all over the body, and of course I have to do the examination quickly. So I will check the tone, especially in his deltoids, in his triceps, in his wrist, as well as in his hamstring muscles, his ankles. Okay, and like so simply I will check the shoulder in the upper limb, I will check the elbow power at elbow joint. I will check the power at wrist joint. I will check the power at hip joint. I will check the power at knee joint. I will check the power at ankle joints. Okay, like simply all the upper limb and lower limb, I'm going to check, assess the power. For example, if the patient is of stroke patient, and what I'm finding is his face muscles are weak, as well as his right upper limb and right lower limb have weak as well, it will point towards stroke. Okay. For example, if I will do the examination and what I found that the left side of the face have weak muscles, whereas the right side of the body have weak limbs like upper limb and lower limb, I will think about some problem in the brainstem, because when we will study, you would know that the brainstem is the one which give cross features. So like quickly I will do that, then quickly I will do a coordination test in the patients. I will ask them to tap my finger with his tap my finger with his finger and tap his nose, and then keep on repeating that. If I want to do that thing in the lower limb, I'm going to go for heel shin test. So upper limb, finger nose test, lower limbs, heel shin test. So quickly I will check the coordination, then I will go for gait. I will ask the patient to walk. I will see either he is walking normally. I will see if there is any foot drop. I will see if there is any hemiplegic gait, any intalgic gait, any broad base gait. I will ask him to do heel walking. I will ask him to do toe walking, just to check like all the things are normal. And then I will go for reflexes, and I will do a bicep reflex. I will do a plantar reflex. I will do a tricep reflex, and if needed, I will go for a patellar reflex. Not needed much, but yes, knee jerk. Okay. If needed, I can do a jaw jerk as well. So I will go for that. And the last thing, I'm going to check the sensations. Okay. I will check the sensation in all the four limbs. I'm going to take a cotton swab. I will touch on different parts on the right upper limb, left upper limb, right lower limb, and left lower limb. I will take a tuning fork and I will do the vibration sense in the right upper limb, left upper limb, right lower limb, and left lower limb. Simply, quickly, just to check. See, I check the touch, I check the vibration. So I check the anterior columns, I check the posterior columns. It goes like this way. So screening neurological examination is done in the hospitals, uh, in emergencies, just to screen out what the patient have. Either the patient have any stroke. If there is stroke, you know what it is pointing towards. Either it's a stroke of the cerebrum, cerebellum, brainstem, okay, or if the issue is somewhere in the spinal cord. So this is how we go for the physical examination in the patients. Okay, so uh, mm, now, guys, like as I told you, it is very important to understand the neuroanatomy. You know, if you don't know the neuroanatomy, believe me, you are not going to understand what I'm saying. A lot of things you are not going to understand. Okay, what I'm talking about. The thing, you know, in neurology is basically um, goes somehow like this way. Uh, Whenever the patient presents with the clinics, the first thing, you know, um, uh, we take the history and we go for the neurological examination. Um, what can be the presenting fees, symptoms in neurology? See, the patient can present with weakness, the patient can present with dizziness, the patient can present with loss of consciousness, the patient can present with tremors, um, the patient can present with loss of power or weakness, the patient can present with loss of sensations, the patient can present with fits or seizures, the patient can present with dementia, the patient can present with memory problems. So like huge number of presentations are there. So whatever, we take the history, we do the neurological examination, and then we interpret the symptoms and signs in terms of physiology and anatomy, And that's an important point, guys, which I'm repeating again and again. If you don't know the physiology and anatomy, how you are going to correlate everything? If you don't know how the nervous system works, number one, and number second, you don't know what is the normal functionality of the nervous system, you're not going to associate the symptoms and the clinical features or the clinical examination findings. For example, what I'm saying is someone, uh, mm, I don't want to give you some complicated example right now because it's the first lecture of neurology. Okay. For example, someone have weakness in the upper limb, right one, as well as a little weakness in the lower limb. When I asked him the history, he said that he have hypertension, he's diabetic, he have atrial fibrillation, and today suddenly he developed these symptoms. See, now I know that his history put him at risk of stroke. Now I make up my mind that okay, it can be stroke. When I did examination, I found that upper limb have more weakness than the lower limb. I will start thinking which part of the brain is gone. And if I will make my thinking like this way, that which part of the brain is gone, I must know the blood supply of the brain. Like that part of the brain is supplied by which artery. And if I know that, then I would say that yes, maybe he have a stroke of this particular artery, which is damaging his this part of the brain, and that's why he have these symptoms. Okay, so see, many things are important. The timing of the symptoms, either it's a gradual onset, either it's a sudden onset, what areas are involved, what features are there. Okay, so then we go for syndromic formulation and localization of the lesion. That's what I'm doing here. Okay, so see, anatomic diagnosis plus mode of onset and course, other medical data, and then we will decide what kind of lab test which we have to do in this patient to reach the diagnosis. Okay, so the discussion here is, guys, you must know that anatomy and physiology of the nervous system is very important to understand a lot of neurology. If you don't know that, how you are going to localize the lesion, how you are going to make the diagnosis. For example, someone who have weakness in little finger, you must know which nerve is gone. Someone who have loss of sensation in any part of the body, you must know which nerve is supplying that one. Okay, and then you have to decide either it's a nerve problem, it's a nerve root problem, it's a problem in the spinal cord, or it's a problem in the brain stem, or it's a problem in the brain upper parts, upper regions. Okay, you can see this one, a very interesting slide. See, whenever someone presents with some features or symptoms, the onset is instant. Think about trauma or vascular cause like stroke, trauma. If the onset is within days to hours, think about inflammatory cause. If the onset is within weeks to days, think about demyelinating disorders like multiple sclerosis. Like I believe, like at this point, you must know what is myelination. Myelination is a protective covering on the nerves, axons, and when that myelin sheath is lost, the functionality of the that neurons is affected. So it could be inflammation, it could be demyelination, but when the onset takes months to weeks, think about tumors or chronic inflammation. But when the onset is in years, it means it could be benign tumor, it could be degenerative conditions like Parkinsonism, like Alzheimer's, like many other conditions. So of course, like when you will learn more and more conditions, guys, you will be having more and more idea what I'm saying. So until now, what we have discussed um, the neurological examination. Watch some videos, like right on YouTube, like neurological examination of the upper limb, um, neurological examination of the lower limb. And by the way, in my channel, you can found, for example, I have subscribed, or I have added some of the playlists for USMLE's step 2 CSS preparation, or PLAB 2 preparation, or AMC 2 preparation. You will find a lot of videos, by the medical students. Very good channel, guys. Follow geeky medics. Okay, geeky medics. So they show very very simple videos for the medical students. Okay, and you can see what you can say. Um, you will learn a lot of things. So, like, subscribe to this channel. Like, not even subscribe, guys. Like, like, you can just write geeky. Even I'm not sure, like, I'm writing the correct spelling, but write the upper limb examination, or the lower limb examination, or cranial nerve examination, and try to watch the videos. They make very simple videos for uh, medical students. Okay, and they go in the same way. ITPRCS, which I told you, or when we will talk about the cranial nerves, uh, they will go in the same way. Okay, so simply localization, diagnostics, all these things need a lot of information. So of course, once we go for the after examination, what we do, uh, we go for the investigation. So, as this is the first introductory lecture, and your course says, like, there should be 3 lectures on just the introduction of neurology, because many students, they are not well, like, too much good in neuroanatomy or neurophysiology. So that's why, a lot of information is needed, what you can say, to tell you what you can say about the introduction of neurology. So I don't know what's wrong with this, because okay, wait, cut. Okay, so what are the investigations we can do? Investigations in neurology, not in neurology, of course. These investigations can be anywhere, but, like, just to give you an idea. See, of course, like, I will not talk about CBC and ESR, CRP, and all the stuff. They are the investigation of almost every condition. Um, okay, yes, lumbar puncture is a good way to start. Lumbar puncture, for example. Okay, lumbar puncture in neurology is very important. Like, for example, to diagnose multiple conditions. Of course, like in infectious diseases, maybe you have learned about meningitis or encephalitis. We can do lumbar puncture. We can take the CSF, and we can see what is the condition of the CSF. Either it's meningitis, either it's infected, what kind of cells are there, and all this stuff. In many inflammatory conditions like multiple sclerosis, we can take a help of lumbar puncture. What is lumbar puncture? Basically, they put a needle inside the um, space, subarachnoid space, and they can take the CSF to study that, to do the analysis of that. Uh, the lumbar puncture needle is inserted between L3, L4, or L4, L5, okay, or even L5, S1 interspaces as well. How we do that, of course, that's a different discussion. So, lumbar puncture is a type of investigation used in many diagnosis workup, for example, to diagnose subarachnoid hemorrhage, um, to diagnose infection, to diagnose inflammation. So lumbar puncture can be used as a diagnostic test, okay, and also it has some therapeutic uses as well. Therapeutic, for example, in meningitis, you can give antibiotics, through this one. For example, someone who have increased intracranial pressure, they can drain out some CSF by doing lumbar puncture. Or for example, there is something called as subdural uh, anesthesia. What they do, they they give anesthetic agent uh, inside that by the use of that lumbar puncture needle. They can do that. Okay, so like that's why we do lumbar puncture, and of course we can do cytology of the CSF. We can do the microbiology of the CSF. We can do a cell count of CSF, and chemistry of the CSF, checking how much protein is there, how much glucose is there, how much. For example, in infections, the protein contents are high, glucose contents are low, and all this stuff. So yes, so to diagnose, like, it have both diagnostic as well as you can say therapeutic applications. CT scans, very important, as you know. CT scans are very important to guide you towards intracranial bleeds or stroke. So CT scans have a very, very, very wide application in neurology. Used too much in stroke patients, in head trauma, to diagnose tumors, and to check to catch any raised intracranial pressure. CT scans have a lot, what you can say, applications. So this thing is there. Um, MRIs can be done, magnetic resonance imaging. Mm, Again, in certain condition, multiple sclerosis, we do T1, T2 weighted images. I hope like you had learned about MRIs in a good way in radiology, like what is their functionality, how they work, and what is their uh, usage. So we can do MRIs in neurology. We can do EEG, electroencephalogram, and that's the reason the Americans say ECG, sorry, EKG to ECG, electrocardiogram. Americans say EKG, just to make it different from EEG. EEG is electroencephalogram, in which like they put like the electrodes on the brain and say they see the brain activity, um, to check like if there is any abnormal waveform in the brain. For example, to diagnose many patients with sleeping disorders, to diagnose many patients with epilepsy, um, seizures, and many other applications as well. One thing in neurology which can be done is called as nerve conduction studies. Okay, what is this kind of study? Is simply they put an electrode on the nerves, and they see like either the nerves are conducting the impulses at the same speed and at the same rate and at the same amplitude. Many of the conditions, for example, in which there is problem with the peripheral nerves, and if they want to establish the diagnosis, either it's the peripheral nerve which is damaged or it is the spinal cord which is damaged, so we can do a nerve conduction study. uh, there are many peripheral nerve issues in which what you can say there is problem with the axons. There are many peripheral nerve issues in which the problem is with the myelin sheath. So nerve conduction studies are used to differentiate between these two, axon problem as well as with the myelin sheath problems. So we can do this test, nerve conduction studies. Electromyographies can be done, EMGs can be done. Uh, so, for example, I don't know how many of you, but like in our pre-medical studies, and especially like when we were in medical school, they let us to do um, what you can say, uh, experiment on the frogs. What they do, like we have to take out a nerve with a muscle from the frog, and we have to give them a stimulus, a current to the nerve, and the muscles that get twitches. So EMGs are somehow like this, that they pass, they give a stimulus, okay, and they see like either the amplitude uh, is passed to the muscle. So just to differentiate, either the problem is at in the muscle or in the neuromuscular junction, or so see NCS uh, is the one which will check the nerve, and when the nerve ends, it ends in neuromuscular junction, and then is the game of muscle. So these two tests are very important to differentiate either the pathology is in the nerve or the pathology is in the muscle or in the neuromuscular junction. Myasthenia gravis, we can perform this test. Uh, Nowadays, of course, uh, because of the advent of what you can say, a lot of new things in neurology or in testing, many more tests are there, you can say, uh, which are available nowadays, which are used for uh, diagnosis. Okay, so uh, like radionuclide scans are there. Okay, contrast scans are there, angiographies are there. Simply like for example, we can see the blood supply to the brain by passing some contrast, and they can see exactly where, like where's the blockage and stuff like this. Okay, so a lot of what you can say, tests are there, of course, like nuclear medicine and all these things. They are like too much, you can say, advanced now. So a lot of new tests are there. Like I'm of course, like we are not going to discuss all of them here, but like just to tell you, they are available, okay, which help in diagnostics. So now, the important thing is to tell you guys here is very important thing is to read the tracks, guys, to know about the cranial nerves, and a lot of your problems will be solved when you will be good in that. For example, like you can take it as a homework, by the way. Go and study about the visual tract, how the optic nerve carries the uh, vision to the occipital lobe, and what are the tracks which are involved, and how the fibers they cross over in the middle, okay, or how optic nerve makes the optic tract and optic chiasma. So like you would learn a lot of things, okay, which I will be talking about in the coming lectures. But of course, I cannot talk each and everything about neuroanatomy and neurophysiology. So it's better to like improve yourself before going on to that things. Rest, of course, like neurological presentations can be many. Like weakness, as I told you, can be one of the presentation. Numbness or altered sensations can be there. Gait disturbances can be there, as well as loss of cognitive functions can be there, fits can be there. So whenever we are dealing with any symptom, we take history, and like how we take history, I think like we have discussed that thing, of course, before like the previous when I've started teaching general surgery. So simply whenever we are dealing with any symptom, we have to find out one very good mnemonic is called as OD para: onset, O onset, D duration, okay, P for progression, how it is progressing, either it's quick or either it's slowly. PA is aggravating factors, and R is relieving factors, and last one is associated symptoms. So you have to check the mode of onset, either it's acute onset, either it's slow onset. We have to see the course simply, either it's progressive type of condition becoming bad day by day, either it's episodic type of condition, uh, like it become worse and then become better, then become worse, then become better. What is the pattern of that condition? uh, what are the associated symptoms, we can get. So of course, like based on these, we can decide like a lot of diagnostics in neurology. So guys, like in the next lecture, of course, like mm, I will be talking about the basics of cranial nerves, and then like the different tracks I will teach you, and then I will take you to more clinical side of the neurology. Okay, so see you guys in the next lecture.